Good morning. Thank you for joining us today to discuss depression screening. My name is Karen Curtis, and I am a provider outreach and specialist here at WPS. Joining me today, I have two of my friends, Aline Sigler, who is a member of our team, and also Mary Sue Gardner, who is a member of my team, but she's also on the clinical side. Aline is going to help me out today by monitoring the chat for questions you may have, and she's going to provide some additional information during the presentation. I do have a couple of things to cover just before we get started. The Training Center website is where you can find information related to the Provider Outreach and Education team. You can find a link on the slide, and it will also be added into the chat. Now, once you are there, you can choose to go to the live events card, which will bring you to a list of all of the webinars that we're going to hold for the next 6 to 8 weeks. You can register for upcoming events and download copies of the presentations that we show during our webinars. Now, if you haven't gotten a copy of today's slide presentation and you would like to get that downloaded, there is still time. Just click on the link in the chat and it will get you there quickly. The Training Center is also home to our Encore Presentations webpage. Videos are available for up to 90 days and they can be watched directly on our website. After that time, they will be removed from the website, but they will remain on our YouTube channel until the information changes. Later, there will be a question and answer session if time permits. If you have questions related to today's topic, please send those using the chat feature. I did receive some pre-submitted questions, which I will answer at that time. If there's any questions that I don't get to, or if some require additional research, then an email providing those answers will be sent to everyone in attendance. At the conclusion of today's webinar, you will be asked to provide feedback on how I did today. This is your opportunity to let me know what I did right, as well as areas that I need to improve on. There is also an opportunity to provide topics which you would like to see in future education. While this is a CMS survey, WPS does look at our results, and we do our best to make the changes that you ask for. Well, here at WPS, we do our best to provide you with accurate, up-to-date education. If you've worked in Medicare for a while, you know that Medicare rules and regulations can change. So for this reason, the CMS website should be checked for updates, and the federal regulations take priority over anything presented today. Questions and answers are based on the facts given, so any changes to that information may change the response. If you have a claim-specific question, we do ask that you contact customer service. They can access your claim and they can provide an answer based on how your claim processed. Lastly, I need to let you know that CMS does prohibit the recording of this webinar. We are recording the event so it can be posted as an encore presentation. So if you feel like you missed something or if there's something that you want to share, you will be able to watch it later either on our website or on YouTube to get those answers. Now, this is a copyright notice from the American Hospital Association National Uniform Billing Committee. This notice is required because I discussed coding that would be included on a UB04 or an 837I. I just need to let you know that the American Hospital Association is not responsible for, nor were they involved in the preparation of this material or the information provided today. Well, today I am hoping that I can increase your knowledge on coverage and billing for depression screening. I plan to do this by discussing a little bit about Medicare coverage of preventive services in general, and then I'll move on to the specific coverage and billing of today's topic. Finally, we'll talk about eligibility and how you can determine if it's time for a beneficiary to receive these services and avoid frequency edits. Now, the world of Medicare is full of a lot of acronyms. I've created this list of ones that you will see or hear during my presentation. Many of you may be aware of most, if not all of these, but I do like to include them in case we have someone who's new to Medicare, or maybe someone who works in a field or practice where they haven't needed to know what all of these mean. If I mention any acronyms that you are unfamiliar with, you will have these slides for reference. So let's start with a little bit of general information. The Affordable Care Act and the U.S. Preventive Services Task Force have helped make preventive services more accessible to beneficiaries. The Affordable Care Act was signed into law on March 23rd of 2010. It required healthcare plans to provide certain services, immunizations, and screenings without cost sharing. The hope was to eliminate some of the out-of-pocket expenses so that more individuals would be open to receiving preventive care. This act also increased access to services by making it unlawful for any healthcare provider who receives federal funding to refuse to treat individuals based on race, color, national origin, sex, age, or disability. Now, the task force is a volunteer group that was created in 1984. The 16 members consist of national experts who come from a variety of fields, including family medicine, behavioral health, and nursing, among others. These individuals make evidence-based recommendations regarding preventive services offered in a primary care setting or services that are referable by a primary care clinician and apply to patients who have no obvious signs or symptoms of a specific disease. Each service is reviewed to determine if there is evidence that the service is effective and that the balance of benefit versus harm, they look at the benefit versus harm to see how reliable the service is. A letter grade is then assigned, and those that receive a grade of an A or a B are offered without cost sharing. Now, the task force current recommendations for depression screening is that adults, including pregnant and postpartum women, as well as older adults age 65 or older, be screened for major depressive disorder. This service receives a grade of a B, which means that it has a high certainty that the net benefits is moderate, or there is a moderate certainty that the net benefits is moderate to substantial. Now, the task force recommendations stated that adults should be screened for major depressive disorder, but what exactly does that mean? Major depressive disorder is also referred to as clinical depression. It's characterized by persistent feelings of sadness, hopelessness, and loss of interest or pleasure in activities. The condition is diagnosed when an individual experiences symptoms for at least 2 weeks, most of the day, nearly every day. Persistent depressive disorder is a chronic form of depression which lasts more than 2 years. Individuals may experience a persistent low mood, irritability, and sleep disturbances on more days than not, but they still may be able to perform their daily tasks. Substance or medication-induced depressive disorder is exactly as it sounds. This refers to depression that occurs as a physiological consequence of the use, abuse, or withdrawal of a substance such as alcohol, drugs, or certain medications. Last, We have depressive disorder due to a medical condition. This is when depression occurs due to a diagnosis of a medical illness. Some diseases which can have an increased risk for depression include a stroke, Parkinson's disease, and multiple sclerosis. It's understandable that being diagnosed with a condition that could affect the way you get around, or it may cause chronic pain that could cause individuals to become depressed. Now, I always like to include some statistics in my preventive service webinars just so that everyone can see how important these services are. Depression is a disorder that affects more than 21 million adults each year in the U.S. When we break that down and we look at older adults, about 1 to 5% who are living in the general community suffer from major depression. For those who are hospitalized, that number jumps to 11.5%. Now, for older adults who require home health care, the number rises to 13.5%. Researchers have not found a single specific cause for depression in older adults, but there are some unique risk factors that don't necessarily apply to younger individuals. About 80% of older adults have at least one chronic health condition, according to the Center for Disease Control. The 10 most common chronic conditions include high blood pressure, high cholesterol, arthritis, obesity, diabetes, cancer, heart disease, depression, COPD, and asthma. Decreased functionality ability in physical and or cognitive capabilities. This can lead to a decline in the individual's ability to perform activities of daily living. Some individuals may lose their driver's license. Now they no longer have the freedom to come and go as they please, and that loss of independence could definitely be a source of depression. Reduced mobility, such as difficulty walking or standing. Chronic pain was mentioned earlier. Financial issues. Many older adults are on restricted incomes after retirement, so having to make changes to a lifestyle that you can no longer afford could cause sadness or hopelessness. Loneliness. So although loss can happen at any age, sometimes it can be overwhelming for older adults when they lose the person that they've been with the majority of their life. Loss of friends may become more common, and for those who are not involved in social activities, it may be difficult to find people to talk to. So now that we've laid a little bit of the background, let's talk about Medicare coverage for depression screening. Depression screening is covered for patients who have Medicare Part B. Deductible and coinsurance are waived for this service. Medicare does not require that a specific screening tool be used. That decision should be made by the clinician. And this allows for providers to determine which tools are best based on their patient's needs. Medicare will cover depression screening once in a 12-month period. So this means that 11 full months have passed following the month in which the test was performed. So for example, if the patient was screened in January of 2025, you would start counting that 11 full months beginning with February. And that means that the patient would be eligible for their next screening in January of 2026. Now, CMS has created a National Coverage Determination, or NCD, for this service. There are a couple of ways that you can view the NCD 210.9, which I'm going to show you. First, let me go out to the CMS website. Aline, can you verify that you can see the cms.gov website?
Yes, ma'am.
Okay, thank you so much. So from here, we're going to choose Medicare, then we're going to go to regulations and guidance, and then we'll go to the manuals. Over here on the left, we're going to go to the internet only manuals. And then you'll see publication 100-3. This is the National Coverage Determination Manual. So we'll click on that. You're going to notice all of them are labeled Chapter 1, but then it's broken down into 4 different parts. So I am going to go to Part 4 because we want Section 210.9. Go back up to the top here. So you'll notice that 210 is for prevention. So if you're wondering if there's a particular preventive service that has an NCD associated with it, this is where you're going to want to look. The table of contents does provide links to the individual sections, so you can select the 210.9 for depression screening, and that will bring you to the information that can be found in the NCD. Now, the other way to find this, let me scroll back up. If we go back to cms.gov, we can click on Medicare, coverage, preventive services, and there's a Medicare Preventive Services tool. This can also be found if you go into the MLN webpage. I personally like this tool a lot just because it has all of the preventive services in one place. Now here we have depression screening. You might notice a T with a circle in it. That means that the services are eligible for telehealth. But right here under the title, we have another link, and that's going to take us to the Medicare coverage database and the NCD 210.9. There is some important information in this NCD, which I'd like to make sure that I cover. In the general section here, you'll find that older adults have the highest rate of suicide among all age groups. Of those who commit suicide, 50 to 75% saw their doctor the month prior, and 39% were seen the week prior to their death. So just another reason why this service is so important. In the last sentence here, you will see that coverage is limited to screening services, and it does not include treatment for depression or other medical complications resulting from depression. It also does not cover therapy. So all of this that we're talking about is just for the screening. If we move to the nationally covered indications, you're going to find that CMS will cover annual screening up to 15 minutes when staff-assisted depression care supports are in place to assure accurate diagnosis, effective treatment, and follow-up. And then it goes on to define staff-assisted support. Now, I do want to talk for a minute about these links underneath the claim processing instructions. I'm going to click on the second link here. And at the top of the transmittal, we're going to see that this replaces transmittal 2431. So if we go back, I'm sorry. Transmittal 2359 was rescinded and replaced with this one. So that's why we don't want to look at this one. We want to look at the most up-to-date one. Now I do want to scroll down to page 3 for one moment. So if scrolling does bother you, please look away for 1 minute. Okay, so the reason I'm taking you here is because CMS is going to provide us with an important definition. CMS states that these services are covered in a primary care setting, and in this transmittal, it provides you with that definition. So right here, it has a primary care setting is defined, and it lists the requirements. It also lets us know what is not considered a primary setting. So this last sentence here says that emergency departments, inpatient hospital settings, ambulatory surgical centers, independent diagnostic testing facilities, skilled nursing facilities, inpatient rehabilitation, and hospice are not considered primary care settings under this definition. So that's something that you'll have to take into account when you're considering billing for these services. Okay, let's go back to the presentation. So now that we've talked about the policy, let's talk about how to submit your claims to Medicare. Service that meet the policy criteria should be billed to Medicare using HCPC G0444. You'll see that the description of that is annual depression screening, 5 to 15 minutes. Now, for providers who bill services on a UB04 or an 837I, this code is accepted on type of bill 13X, 85X, 71X, and 77X. For providers who submit claims on a CMS 1500 or an 837P, then the applicable place of service codes include 11, 19, 22, 49, and 71. Now, when we were on the CMS website taking a look at the Medicare Preventive Services tool, I mentioned that the T with the circle in it meant that the services were eligible for telehealth. So if the services are being provided via telehealth to a patient that is located within their home, providers should use a place of service code of a 10. If the patient is somewhere other than their home, then the claim should be billed using a place of service code 02. On the resource slide, I have included a couple of telehealth resources in case you need those for further information on telehealth billing. Well, there are some bundling rules that go along with depression screening. When I hold my webinars on the initial preventive services, or I'm sorry, the initial preventive physical exam and the annual wellness visit, I always get asked if depression screening can be billed separately. Well, if you look at the IPPE and the initial annual wellness visit, there is a component that states providers should review the patient's potential depression risk factors. So for this reason, the NCCI tables list that code G0444 should not be billed with a G0402 or G0438. Now, I also receive a lot of questions about billing for depression screening with an evaluation and management code. And because there are so many different scenarios, I find it best just to consult with the NCCI procedure to procedure edits. I have provided a link on this slide, and I did download a copy of the practitioner's spreadsheet, so you don't have to wait for me to download it. Now, if you aren't familiar with the NCCI procedure to procedure edits, there are some encore presentations on the topic that go more in depth than what I'm going to cover today. But you can see that this spreadsheet has a column 1 and a column 2. Now, there are effective and deletion dates, a modifier column that lets you know if the code pair is not allowed or if it's allowed with the use of a modifier. The 9 is used when the code pairs have a deletion date that is the same as the effective date. So for column 1, this is the payable code. I'm going to do a search, and I'm just going to do 99202. So we're going to make sure the 99202 is in column 1, and I want to scroll until I find G0444 in column 2. So again, if scrolling bothers you, please look away for one moment. I'll try to scroll a little bit slower. Oops, I'm sorry. Scrolled too far. Okay. Apologize for that. Okay, so here we have the 99202 with the G0444. This line has a termination date, so we'll look at this line, and it does have a modifier of a 1. So here you can see that G0444 can be billed with 99200 when an appropriate modifier is applied. So hopefully this makes sense to everyone. You're just going to want to make sure that that evaluation and management code, you're going to want to make sure you're putting that in column 1 and then checking for G0444 in column 2, because the column 2 code is the one that's going to be bundled and not be paid. Now, I had said that depression screening was not separately billable when the patient received their initial annual wellness visit, but it is allowed to be billed separately when the patient is being seen for subsequent annual wellness visit. And that's because the subsequent visits do not have that separate requirement, which specifically states to review the patient's risk factors for depression. Now, there are some special rules when it comes to rural health clinics and federally qualified health centers. G0444 is not separately payable with another face-to-face encounter on the same day. Now, there are exceptions. Both RHCs and FQHCs can bill unrelated services indicated by using modifier 59. Now, for FQHCs, this rule does not apply when billing for diabetes self-management training or for medical nutrition therapy services. Eligibility is another topic that I always like to cover in my preventive services webinars, just because these services are subject to frequency edits, and I definitely want to take the opportunity to help you avoid claim rejections. And you do have a couple of options when it comes to checking patient eligibility. We have the WPS Secure Net Access Portal, often referred to as the portal. Users must be registered with WPS to view a beneficiary's eligibility information. When you visit the WPS website, there's a box that takes up the majority of the screen, and this is where you can register or log in if you have an account. The HIPAA Eligibility Transaction System, or HETS, is available for both Part A and Part B providers, and it provides access to eligibility data in a real-time environment. This option involves submitting files via electronic data interchange, so a trading partner agreement is required. Providers, clearinghouses, and third-party vendors can submit a 270 request, which will be processed and a 271 response will be received. Response files are accurate at the time of transaction, and they should not be interpreted as a guarantee of payment. Now here's an example of how the information is going to look within the portal. When you select the eligibility function on the home page, you'll be required to enter the patient's Medicare number, their first name or date of birth, last name, and starting and ending dates of service. If all the information is entered correctly, the patient's information will display, and you will see the boxes listed here. The blue boxes mean that information is available for those topics, while the gray boxes indicate that no information is there. So here you're going to want to select the Preventive Services button, and then any preventive services that the patient has received will be listed. The bottom picture here shows an example of a patient who has received annual depression screening services. So the procedure code lists the G0444. The next eligibility date shows 10/14 of 2011. Since coinsurance and deductible do not apply, the additional fields for deductible amount, deductible remaining, and coinsurance amount will all show zeros. I have some resources listed that will help with billing the service. The Medicare Claims Processing Manual, Chapter 18, which is dedicated to preventive services, does give specific coding information. We quickly looked at the Medicare Preventive Services tool, but I would like to go back out there for a moment. I mentioned that if the service has a related NCD, the link will be provided directly under the title. I also wanted to call your attention to the What Has Changed box over here on the right. This lets you know if the information has been updated, and if so, what the update was. I have also found that there have been times that the information on this tool is updated before the internet-only manuals, which is another reason why I like to use it. Here you can find the HCPCS and CPT codes that would be used for billing. If a specific diagnosis code is required, it will be listed in the ICD-10 code selection. It gives Medicare coverage criteria, frequency, and patient responsibility. Now down here in the other notes, it does provide additional related information and links. So it has information about safety planning intervention. It gives a HCPCS code. If you click on that HCPCS code, it's going to give you information about billing that also. We have another one, the G0544. So I just wanted to call your attention to that too, so that you did see that there are other services that it gives information about, and you can click on those links to get billing information. We already looked at the NCD, but I would like to show you another resource. It's WPS resource, and it's this depression screening fact sheet. This resource provides a lot of great information and additional resources for depression screening. I did receive a lot of questions regarding documentation, specifically documenting time. I looked at the article debunking the myth that was provided by one of the registrants, and it states that there is no requirement from CMS to document the amount of time spent. The article also says that the CMS changed the text descriptor for HCPCS code G0444 in a January 2023 MLN document. Now, the specific document was not listed, but with some digging, I found out that it was MLN Matters article 7637, which unfortunately is no longer available on the CMS website. Now, the best advice that I can give is that G0444 is now described as annual depression screening 5 to 15 minutes. So it is a time-based code. And by submitting this service to Medicare, you are telling WPS and CMS that you spent 5 to 15 minutes administering a screening tool, interpreting the results, and using the results as appropriate. Another thing to consider is that just because the service is not being medically reviewed at this time, it doesn't mean that services won't be reviewed in the future. Now, if MACs run data analysis and they find high error rates or questionable billing practices or a financial risk to Medicare, CMS has authorized MACs to conduct targeted probe or educates. You may hear those as TPE reviews. So it is just something to consider. Just because it's not necessarily being reviewed right at this moment, it could be in the future. And you're just going to want to make sure that your medical records do document the services that were provided and that they were provided appropriately. Here was the resources I also talked about telehealth in case you would want more information on that. Now, I believe I answered the other pre-submitted questions with the presentation, so I'm going to go ahead and I'm going to ask Aline if we have gotten anything submitted through the chat.
Hi, Karen. Thanks for that great information. I do not see any questions in the chat at this time.
Okay, great. I will go ahead and I will move forward then. After the close of today's webinar, you should receive a thank you for attending email. There are two sections that I would like to draw your attention to. The first is titled Your Opinion Matters, and it's going to give you another opportunity to provide feedback if you haven't already done so. The second section is titled Certificate of Achievement, and this gives you proof of attendance and contact hours that can be submitted to your crediting organization for continuing education units. Now, if you don't get this email, please check your junk or your spam folder. You'll also need to add messenger@webex.com to your safe sender list to avoid these issues in the future. Now, if you joined only by phone, WebEx is unable to generate this email. So we ask that you send an email to the education mailbox with your name and the phone number that you used to join so that a certificate can be emailed to you. Now, if you think of any questions after the webinar, you do have 7 days to send those in. You can email those to the education mailbox shown here on the screen. Be sure to put today's topic in the subject line so that staff will know that your question is related to this webinar and that they'll send it directly to me. Remember, if your question is claim specific, those should go to customer service. Now, when you disconnect from the webinar, you will be redirected to a CMS survey. I'm also having Aline add a link in the chat. I really hope that you'll take a moment to provide feedback on how I did today. The redirect is going to look like what you see here at the bottom, and we don't have any control over how this appears, so we just want to let you know it's not spam or anything malicious. Now, some people may wonder, what do you do with our survey comments? Does it really make a difference? And it does. Here's some changes that we have made based on survey comments. We added chapters to our YouTube videos. That way you can kind of jump around to certain sections that you want to hear or maybe want to review. It just helps you find the information easier. Training indicators were added to our webinar descriptions so that you would know, is this going to cover technical information? Some of our topics maybe apply to FIS but don't apply to MCS. So just made things easier for people to know if they wanted to attend that webinar or not. We also started doing Medicare education expos. This summer we held one and it was a whole day dedicated to LCDs and NCDs. We had a bunch of webinars. We are going to have another one next week. The topic of this one is going to be the life of a claim. So I'm going to take you back out to our website real quick. If you go to the Training Center and click on our live events page and scroll down to the 16th, we have a bunch of them listed, but if you just click on the one, it will give you all of the events that we're going to hold that day, a description, and then a link so that you can register. So if that's something that you're interested in with the life of the claim, please be sure to go check that out and register for some webinars. But that brings us to the end of today's presentation. I want to thank you for joining us today. On behalf of myself, Aline, Mary Sue, and the Provider Outreach and Education team, thank you for being here, and I hope that you will join us for future events. You may now disconnect.